Well, the WHO is stating something that is factually correct, just as it stated back in 5th of January that SARS-CoV-2 had shown no evidence of person-to-person transmission. At the time, that was factually correct. But what our job to do is to look forward and to look and try and extrapolate from other viruses that may give some indication of whether high antibody titers may confer some immunity. And just looking at that one particular use of antibody testing, there's a reasonable degree of evidence to suggest that for those patients with high enough titers, there may be immunity of perhaps a year or perhaps even more. Now, there's obviously uncertain and unanswered questions here, but that in itself is very important. The second point of doing antibody testing, and you referenced it really in Andrew Cuomo's comments, is it enables you to give some snapshot, albeit not perfect one, of the extent of the infection rate historically in a given country and in different parts geographically. And without having some way to characterize the enemy, you really can't begin to fight it. So for two separate reasons, both the potential to use it as a de-risking strategy to get patients or individuals back to work, but also to help characterize the extent of geographic spread, there is enormous value in pursuing this despite the challenges that exist.
Let's talk about that pursuit and your assumptions. What percentage of the population can realistically be tested with these antibody tests, and when? What's the kind of time frame that you're looking at?
Well, there's a number of different tests available on the market, but the ones that have been available historically have largely been point-of-care tests. They all come out of China. These are effectively like self-administered pregnancy tests. The problem is these haven't been validated, and many of them really aren't up to scratch. They don't do what they say on the label. Some do, but they're the minority. There is a large enough degree of volume, but in reality, I think what's going to form the bedrock of testing in the US and beyond is tests which are done in laboratory facilities based on a blood draw. And in terms of the scalability of these tests, Roche announced a couple of days ago that their Alexis assay would be able to test up to 100 million patients a month from June. And we imagine maybe half that during May. So they'll be scaling very, very fast. And of course, you don't need everyone to get tested on day one. We're going to first prioritize, number one, for healthcare workers and key personnel. And then we're going to prioritize the young, fit patients who don't have pre-existing illnesses, because that's the cohort really that you want to send back, knowing that the risk of harm is going to be less than, let's say, a 68-year-old patient with a history of cardiovascular disease.
Hi, I'm Joanna Bersecci, and thank you for watching. You can check out more of our videos by clicking on the boxes on the screen. And don't forget to subscribe to our channel for more from CNBC International. Thank you for watching.